Dzień dobry, Bartosz Kinas, witam Państwa serdecznie. Znajduję się obecnie przed kliniką IOZK w Kolonii. Za chwilę specjalnie dla Państwa będę rozmawiał z głównym onkologiem, profesorem Stefanem Wangolem. Serdecznie zapraszam do obejrzenia wywiadu, zapraszam do komentowania i zadawania pytań w naszych mediach społecznościowych. Dzień dobry. Szanowni Państwo, mam dziś przyjemność rozmawiać z profesorem Stefanem Wangolem, który jest dyrektorem medycznym onkologii translacyjnej w klinice IOZK w Kolonii. Witamy, doktorze. Hello, doctor. Thank you for having us.
Hello.
Zadajecie Państwo wiele pytań w komentarzach, w mailach, w rozmowach telefonicznych. Na dzisiaj przygotowałem kilka pytań, kilka najczęściej zadawanych pytań. Mam nadzieję, że uda się rozwiać troszkę wątpliwości. Pozwolę sobie zacząć od pytania odnośnie terapii. Panie doktorze, czy mógłby nam Pan powiedzieć, jaka metoda leczenia raka jest oferowana w klinice i z czego się ona składa?
Well, the term method of cancer treatment is in fact a very important term. It's a treatment consisting of several pieces of treatment, and they all have the common term immunotherapy. But there are several approaches of immunotherapy which we include in this global IOZK treatment, so to say. You have immunotherapies that are rather aiming to kill tumor cells, thereby inducing an immune response. That is called immunogenic cell death immunotherapy. This consists of injections of oncolytic viruses and sessions of modulated electrohyperthermia, where we try to kill tumor cells, thereby inducing an immune response. Then another type of immunotherapy is the vaccine therapy, and there we have dendritic cell vaccines, but we have also long peptide vaccines, and with these vaccines we aim to stimulate the immune response in the body. So it's a completely different type of immunotherapy. And then a third type of immunotherapy is the modulatory immunotherapy, where we try to modulate the interaction between the immune system and the tumor microenvironment. And here the checkpoint inhibitors are very well known, but in-depth anti-inflammatory therapies are also important in this modulatory immunotherapy. So we have immunogenic cell death immunotherapy, vaccine as active specific immunotherapy, modulatory immunotherapy, but we also have passive immunotherapy when the indication is possible that we can use antibodies to kill tumor cells. So there are many forms of therapies that we combine here within the global treatment plan. And this in combination with insights that appears from the literature and from own experiences. For instance, the cancer neuroscience, where we know how the neurons can stimulate the tumor cells so that we can block at this interaction. So all these novel insights are also somewhere included in the global treatment plan. So it's really a treatment much more than only dendritic cell vaccines, which are available also in other centers, but we give a global treatment, and this global treatment should then be integrated within the standard of care. So you cannot combine everything at once. You should really make a strategic plan in multiple phases, with each phase having an own goal in the global strategy against the cancer.
Panie profesorze, proszę pokrótce opisać, czym jest szczepionka dendrytyczna i na czym polega jej działanie.
Dendritic cell vaccines are a novel cell-based therapy And the principle behind is as follows. So you can take blood from a patient, and out of one of the blood cells you can differentiate in the laboratory immature dendritic cells. And these immature dendritic cells, which are coming from the patient, can then be loaded with tumor antigens that are also coming from the same patient. And then after loading the immature dendritic cells with the tumor antigens, you have to give a danger signal to obtain mature dendritic cells. And one important element are these danger signals, because there are many possibilities, and it should of course be very perfect, because otherwise your vaccine will not work. On the contrary, it might induce tolerance. So the system that we use here at the IOZK is the combination of the classical cytokines mixture that are used for maturing dendritic cells, but we use also Newcastle disease virus, which is also used in the immunogenic cell, that immunotherapy. So this Newcastle disease virus is an essential element that we use as danger signal to mature the dendritic cells. And that goes over the toll-like receptors. So then you have cytokines and toll-like receptors together to give a very active, mature dendritic cell. These dendritic cells are then injected within the skin. That's the place where they are usually behaving at best. And the dendritic cell that is injected in the skin has to do its normal job. That means move to the lymph nodes. And in the lymph nodes, the vaccine, the dendritic cell, will then stimulate the immune cells, and at the end the immune cells have to go to the place, the cancer, where they have to do their anti-cancer job. So that is the general principle of a dendritic cell vaccine. Dendritic cell vaccines are now considered as advanced therapy medicinal products, ATMPs, and of course the whole regulation is now in place within Europe, and all the requirements are defined to create an advanced therapy medicinal product, a dendritic cell vaccine, and this is available here at the IOZK.
Panie profesorze, profesor Ralph Steinman w 2011 roku otrzymał nagrodę Nobla za odkrycie komórek dendrytycznych. Czy mógłby Pan powiedzieć coś więcej na ten temat?
Well, sure. I have known Professor Ralph Steinman himself personally. I was in his office and he was very supportive to see how his discoveries in the preclinical animal models were translated into clinical reality. And he was very supportive also to my idea to do these dendritic cell vaccines for brain cancer, because at that time it was only in the melanoma world that these dendritic cell vaccines were explored in clinical reality. In fact, Ralph Steinman won half of the Nobel Prize because he really developed the idea that a cell is an antigen presenting cell, so he discovered the dendritic cell. But Beutler and Hoffman, the two others who won the Nobel Prize in 2011, they gave the insight that besides this dendritic cell as carrier, as antigen presenting cell, you need also a danger signal to get the immune system stimulated. And this combination of the dendritic cell as carrier and the danger signal as a real essential signal for immune stimulation, that is what the modern vaccines make a clinical reality today. And at the IOZK we produce our dendritic cells and we give a unique combination of danger signals. We use the ionolite cocktail cytokines together with Newcastle disease virus, which is a toll-like receptor, so that you have a synergy between these two danger signals on your dendritic cell that you produce. So, and this is the vaccine, and as I have explained, we give such a vaccine now after the chemotherapy, because this immunization phase should not be affected anymore by the chemotherapy. And then, very interesting, besides this Nobel Prize, there was a second Nobel Prize in the last decennium in 2018 with the checkpoint inhibitors, Allison and Honyo. So they have then discovered how is now the regulation of this immunization and the regulation of the anti-cancer effector response, how is that going on? And apparently you also can influence these regulations in the immunization and in the anti-cancer effector phase. And these are the checkpoint inhibitors. And of course, in our individualized multimodal immunotherapy, we take into account these two Nobel Prizes. First of all, we make our dendritic cells, but we can also use these modulatory immunotherapy elements like checkpoint inhibitors to regulate then the immune response within the tumor.
Panie doktorze, proszę nam powiedzieć, czy klinika IOZK to jedyne miejsce w Europie, gdzie można leczyć się szczepionką dendrytyczną?
No, dendritic cell vaccines are produced at several places in Europe, but there is a big difference between what we produce as compared to the other places. First of all, as I have already explained, our dendritic cell vaccine is only one element in the individualized multimodal immunotherapy. As I have explained, we have immunogenic cell-death immunotherapy, dendritic cell vaccines, long peptide vaccines, modulatory immunotherapy, passive immunotherapy, eventually even adoptive immunotherapy. So dendritic cell vaccines is only one element. We have also much more experience to integrate this individualized multimodal immunotherapy within the standard of care, because also there a lot of experience is required to get the results. And finally, if you look purely to the dendritic cell vaccine, there is also a major difference. As I have explained, these dendritic cells are differentiated out of monocytes, white blood cells. That's the simple part. The more difficult part is which antigen do you put on the dendritic cell, and there we have particular technologies. And last but not least, how is your maturation of your dendritic cells? What is the danger signal? And there we have the approval that we can combine our Newcastle disease virus, which is also used in the immunogenic cell-death immunotherapy. This Newcastle disease virus is also used as part of the danger signal in the maturation of the dendritic cells in combination with the cytokine cocktail that is classic. So there also there is a unique element in our dendritic cell vaccine. So I think all in all, the clinical experience, the combination treatments, and then the unique features of the dendritic cell makes the situation at the IOZK different as compared to the other places where you can receive dendritic cells, but only dendritic cells.
Panie profesorze, bardzo ważne pytanie, bardzo często zadawane przez pacjentów. Czy istnieją jakiekolwiek badania naukowe potwierdzające skuteczność tej metody?
Yes, there are. First of all, there are preclinical studies in laboratories where the system is completely worked out. So you can do in the laboratory experiments with cell cultures. You can do in the laboratory experiments with animal models. But of course, the biggest translation and most interesting for the patient is what are the experiences in the humans. There we can say for the brain cancer group, but also for other diseases, that indeed in phase 1, phase 2 and randomized phase 2 trials, evidence is appearing that this method is really giving a success and that you can significantly improve the overall survival of patients. There are also already meta-analyses of phase 2 trials that sample all these trials together and prove that this treatment improves the overall survival in patients. The challenge now is to go to randomized controlled trials. There you need much bigger groups of patients and you need the appropriate controls. And there the challenge is because in such type of immunotherapy, like we do within a standard of care, you have not only the diversity of the tumors, but you have also the diversity of the immune system and how this immune system is reacting against the standard of care. So to design an appropriate control group compared to your experimental group, this is virtually impossible. So, and there at the moment we are a little bit blocked in the classical design of phase 1, phase 2, phase 3 trials. So to solve this problem, we have treated a lot of patients and we have looked retrospectively and categorized these patients within the classical clinical risk profiles that such patient has. Not only clinical risk profiles, but also important molecular profiles at the tumor site. And then again, if you compare to contemporary publications, we see an enormous shift in the overall survival of our patient group. So that means that this is a real world data in comparison to clinical trial data, but if it is overwhelming, then it is also convincing. And that is in fact where we are at the moment, and I think we should proceed further in this direction, and at the end, in this way you also prove that the overall survival is really shifted in a good direction.
Dobrze, zatem następne pytanie. Wielu z pacjentów pyta, czy terapia jest skuteczna i czy klinika dysponuje jakimikolwiek danymi statystycznymi odnośnie leczonych przypadków. Jak to się kształtuje?
Yes, we try to publish our data at a regular frequency, having more and more patients. We compare the data that we obtain regarding to the overall survival in comparison with contemporary clinical reports that are available in the literature. So it's hard to have real statistical tests, but at least you can compare the data, and there we see for at least the glioblastoma that we have really a major shift in the overall survival. So we see that the percentage 2-year overall survival is doubled as compared to the contemporary trials. So although we have not the pure statistical test, if you have a doubling of the percentage 2-year overall survival, you do not need statistical tests to see that there is an effect. Of course, with other disease entities that are also treated here at the IOZK, it becomes a little bit more difficult because these patients come at a different time point in their disease course. There's a very heterogeneous group of patients, and of course then to prove that you have an effect in comparison to very well streamlined cases that are eventually reported in the literature, it becomes very difficult to get there the appropriate statistics ready. And whatsoever, this is not in fact the most important. The most important for a patient is the individual response to treatment. So even if you can say, well, 60% will do it well, for a new patient you never know, will this patient be in the 60% or in the 40%. So I think besides the statistics, you need to look to the individual response to treatment. And I think the statistics are important to support the strategy. If you have never shown that it works, then you have to accept that it does not work. But if you have shown that it works in a certain amount of patients and really makes a difference, then this is motivating to discuss these treatment strategies with a new patient and say, at least in some patients it has really worked. You never know that it also might work in your case. And I think this individual response to treatment should be stressed always and always again, because that is for the particular patient in fact the most important.
Proszę nam powiedzieć, czy terapię można stosować we wszystkich nowotworach i czy są jakieś określone rodzaje nowotworów, które reagują na terapię najchętniej?
Yes, the mechanism behind is in fact the most important to consider. So what you need is a tumor with an antigen that is recognizable by the immune system, and you need an immune system that can recognize the tumor. So nothing more is needed. So this is what you call an agnostic therapy, which works in all the cancers where you have the antigen and a functioning immune system. That is in fact what is most important. So we do not do the hemato-oncological cancers, so leukemia, lymphoma, multiple myeloma, because there the standard of care is already so much evolved that there is no need for such innovative treatments. But in all the solid tumors and in the brain tumors, such novel therapies might be considered to be explored now, because there is still the need, and there is also the possibility. And we have here also a spectrum of many types of cancers. So the brain tumors are the biggest group of cancers because of the particular experience that is here available. But besides the brain tumors, the digestive tumors, colorectal cancers, gastric cancers, esophageal cancers, pancreatic cancers are also present. The breast cancers in different forms, hormone positive, hormone negative, the urological cancers, kidney cancer, prostate cancer, lung cancer, small cell lung cancer, non-small cell lung cancer, gynecological tumors, cervical cancers, ovarian cancers. These are all types of cancers that are now here present in patients that we can treat, yes.
Czy terapię można łączyć z leczeniem konwencjonalnym? Mam tu na myśli chemioterapię i radioterapię. I jako kontynuacja tego pytania, czy lekarze z kliniki IOZK mogą współpracować z lekarzem, z onkologiem prowadzącym w Polsce?
Yes, this is in fact the most important point maybe that you mention now. Immunotherapy and these innovative therapies, they have been placed late in the disease course, and then it's of course very challenging, and that's not the good strategy. We need to place the different forms of immunotherapy already up front, even in the first line treatment. And then indeed one should try to combine immunotherapy modalities with the standard of care, because the patient has whatsoever right to receive the standard of care. And then we have worked very strong on the appropriate combinations. So we can indeed combine radiotherapy and chemotherapy already with some modes of immunotherapy. Certainly the immunogenic cell death immunotherapy, the oncolytic viruses, the modulated electrohyperthermia, they can be combined with chemotherapy and radiotherapy. And the aim is the anti-cancer treatment. Starting with full dendritic cell vaccines or long peptide vaccines during chemotherapy appears not to be the good combination. So you have to work in multiple phases, standard of care plus immunogenic cell death immunotherapy, and after all the chemotherapy, a second phase starts with the immunization to get the immune system controlling the residual cancers. So, and that strategy that is developed and that is going in reality each day here can only be done when we work together with the local centers that give the standard of care. So we are very, very open for collaborating for each patient and sharing all the data about this patient with the local oncologist, because both have their importance and should be combined in the best appropriate strategic plan. So indeed, this is extremely important for the patient.
Panie profesorze, czy ta terapia jest bezpieczna? I jakie efekty uboczne mogą się pojawić po jej zaaplikowaniu?
Well, yes, that is a very particular element in such a multimodal immunotherapy is the extreme safety. So you should imagine the surgeon and the radiotherapy and the chemotherapy. These are external toxicities that you put on the patient. While with the different forms of immunotherapy, in fact, you put not an external toxicity in the patient, but you let it happen in the body itself. And there the toxicities are in fact absent or very minimal. It might be that the patient experiences the effects of the therapy. For instance, in brain cancer, if the immune system is active, it might be that you have some edema reaction, but that's then not a side effect, but that's then part of the effect, which then will disappear once the thing is done, so to say. So this is a unique and also a unique opportunity for immunotherapy, is that it is almost not toxic.
Jak wygląda schemat leczenia i ile trwa terapia?
Well, so we always have to, and I did this morning, we have to ask to the patient what is the standard of care treatment plan. And then we start to integrate within the chemotherapy blocks already these 5 days immunogenic cell death immunotherapy blocks that are given here. So then you have a period of chemotherapy, ICD immunotherapy, next chemotherapy, ICD immunotherapy, and so on. And that runs as long as the chemotherapy runs. So this is depending, in fact, on the standard of care. After the chemotherapy, we start with the immunizations, these are normally 2 8-day vaccination cycles, where the patient is here then for 8 days with an interval of 3 weeks in between. And then we start with a very important third phase in the therapy. This is the maintenance ICD therapy, because we know that these tumors try to escape the immune control. The tumor tries to go to the left or to the right, and we believe strongly that with further maintenance immunogenic cell death immunotherapies, you also kill the tumors that goes to the left and kill the tumors that goes to the right, and put them in this global immune protection that you install and that you have to expand more and more because these tumors try to escape to it. So after the initial anti-cancer phase, chemotherapy, ICD, immunotherapy, after the second phase, vaccination therapy, we install a third phase with maintenance immunogenic cell death immunotherapy, which then fades out slowly over the time. And then this is the global schedule. This is not predictable as such. This is also depending on the individual response to treatment that we see in the patient. But that's the global schedule that we have. 3 phases, an anti-cancer, an immunization and a maintenance.
Panie doktorze, oczywiście jedno z najczęściej zadawanych pytań, ile to kosztuje? Zazwyczaj pierwszym pytaniem we wszystkich mailach, w komentarzach, w rozmowach telefonicznych są pytania o koszta terapii.
Yeah, it's of course a very important element. So as we have already explained, the treatment plan is ideally plugged into the standard of care. And of course, when the standard of care changes, we have also to change our treatment plan. So we always make a diagnostic procedure in the beginning, an evaluation of the global treatment strategy. And then we have to plug in the treatment modalities, the immunotherapy modalities that we have here available. So the cost will depend on the ultimate treatment plan. And of course, the longer the standard of care takes, the longer the immunogenic cell death immunotherapy takes, the more costs at the end will be done, because the costs are here calculated per medical activity. So we do not sell products, but we give treatments with a cost that is defined by the German law for ambulant treatment. Now, if you put that somewhere globally together, one can say that a normal cost per year for a cancer patient in the standard of care is roughly about 75,000 euros. As I have said, the standard of care is an anti-cancer treatment that focuses on external toxicity to the cancer. Now we have the immunotherapy, which is an intra-person stimulation of the immune system. So you can say that approximately another 75,000 euros is created by these immunotherapy strategies in combination with the 75,000 euros by the anti-cancer strategies. So then you work on both sides, the anti-cancer and the immunotherapy. So roughly 75,000 euros can be somewhere put forward. Of course, if it comes to particular modulatory immunotherapies where we need to use particular drugs on top of that we have to buy in the pharmacy, these costs on top of that, and these costs are depending on the amount that the company asks that we can sell these antibodies, for instance, for the checkpoint inhibitors. And then the costs are of course changing due to the fact that we have to buy these antibodies in the pharmacy. So globally, a cost plan can be created for each patient once we have insight in the treatment plan then the cost plan will come, and this cost plan will then further be adapted along the road that we go together with the patient, and at the end we see where we come out. So it's very difficult and in fact principally impossible to give a fixed amount of cost. It is always titrated on what is happening in the patient.
Panie profesorze, bardzo dziękujemy za zaproszenie, za poświęcony nam czas. Dziękujemy za szczegółowe odpowiedzi i mam nadzieję do zobaczenia przy najbliższej okazji.
Bye bye.